we have 3 themes for this event, and the first one is quality. You heard a lot in Sally's story that I think we would all collectively agree is not the highest quality care and experience that a person in that situation could have. And why we were thinking about quality as a central theme is raise your hand if you feel like you don't quite have the resources or the infrastructural support to provide what you feel like patients need. All right, almost everybody. So we are in this situation where we are all trying to do the absolute best that we can for our patients in the context of constraints, in the context of shortages, in the context of the system as it is today. So we are trying to do the best that we can in this situation at the same time as we are trying to hang on to a vision of a future where it is easier to provide that higher quality care that we want to provide. We've got our feet in both canoes. And the speakers you're going to hear from in the next day and a half are doing exactly that, figuring out really innovative ways to thread the needle, given the current parameters, and provide really high quality care to patients, and leaders who are advocating to change the system so that it's easier for that to become the standard of care. Second theme for this conference is equity. I come from the palliative care world. In the palliative care, our mission is to do everything that we can to address patients' suffering, to really understand what matters to patients so that we can align care with what's important to them, and to do everything that we can to improve quality of life. And if we don't have equity in mind, if we're not thinking about that, we cannot fulfill on that palliative care mission. Where we see inequities based on race, based on region, based on sexual orientation, based on cultural background, that is suffering that as a health system, we're not addressing that we could be. And so we, both organizations, CAPC and C-TAC, are really focused on this issue, and not in a admire the problem, wave our hands about it kind of way, but in a what can we do about it to start to work more closely towards health equity. So tomorrow morning, that's the focus of our keynote, that's the focus of our breakout sessions, and you're gonna hear from a lot of health equity champions who have really made a difference in their communities, who are gonna be sharing out their work. We're gonna be talking about a policy advocacy agenda to start to systematically chip away at race-based disparities for patients with serious illness. And our third theme is workforce. And we all know we could design the most beautiful care delivery model in the world, but at the end of the day, it is people delivering that care. And we have workforce shortages right now. We have a workforce that is burdened by having come through the pandemic. We have a workforce that is at risk for feeling undervalued for the work that they're doing. We have a workforce that isn't always adequately prepared to meet the needs of patients with serious illness. And so collectively, we're thinking about all of those issues, strategies to address all of those issues. And that'll be the focus of the keynote that comes after this session and of our breakout sessions this afternoon. So those are 3 themes, but obviously what sits at the foundation of all of that is the stories of patients and of caregivers like Sally. And we sent a survey out to all of you, thank you to those of you who answered, after you registered, and asked what is it that, in the face of some challenges to the work that we do, what is it that really keeps you motivated and driving towards improving care quality for patients with serious illness? And a ton of you said, those connections, relationships with patients, knowing what a difference I'm making in patients' lives, that's what nourishes me, that's what keeps me energized to do this work. So that was a pretty constant theme throughout all of those responses. Excuse me. And there was another survey response that said, when I think about what we put patients through, what we make them cope with, to not be working towards improving serious illness care is unthinkable. And that really resonated with me because I suspect most of us feel a calling towards this work based on people we love and personal experiences that we've had. And at the same time, we can feel pretty frustrated by how hard it is to improve the quality of care that we provide for our patients. So I think, we are sitting here today in this moment of both a lot of headwinds and a lot of tailwinds. And our hope for this summit is that together we can be charting a course to what are those strategies, what are those key areas of work that we want to be collectively working towards to drive change. And that's the goal for these days. Nothing gets done in Washington. How many of you came to this conference with that in mind? Another policy discussion, great. Well, I think you're going to hear over the next day and a half that things are happening, change is happening, and in my time in this work, I've been around a lot of the early pioneers on hospice, and I sit in meetings and I hear them tell the stories about the old days, and it's made me come to the realization that hospice was really revolutionary. Now, just set aside the actual hospice and how it's delivered today. We know that there's good there. We know that there's improvements that could be made. But if you think about it as policy change, how it happened, what was in it, it's really unprecedented. And I think we've almost become comfortable with how innovative it was and how many of you built an incredible foundation for us to think about the future. So two things. One is it shows us that incrementalism isn't always the best way to think about change. So the hospice model, the federal government pays for spiritual support. Talk to this average person, they're going to find that incredible. It's going to become almost the norm for us, and when we think about this, focusing on both the patient and the caregiver, an interdisciplinary team, community-based, all of these things are great foundations to build on, and it was unprecedented in this country. It was unprecedented. There wasn't a workforce ready to deliver this care. It had to be created. So when we think about the future, it's ours to shape. It's ours to shape. And it may not look completely like it has in the past. So we should think about, get that hospice mentality in the 70s when it was created and the innovators put it together. Let's apply that. The second is the pace of change. So in 1974, it came to the States, first hospice was created. It was supported through volunteers and bake sales. And in 8 years, through some of the same strategies Bren's talked about, grassroots organizing, policy change, preparing the workforce, it became a Medicare benefit, 1982. 8 years. That may seem like a long time. Trust me, in Washington, that's lightning speed. And so there's two stories to be told there, a positive one, but also a cautionary one. The positive one, fast change. The cautionary one, it's been unchanged for the past 40 years. So what does that tell me? What does that tell us? Well, it tells me that when you have your chance, you got to take it. You got to take it. We have to take it. This is our opportunity. What we do in the next few years is going to define the next 40, 50, who knows how long. The same signs are here around policy change, grassroots organizing, workforce reform, CAPC and C-TAC coming together, you coming together. This is all brewing, and we are on the cusp of creating the standards for the next decades ahead. We are so on the same page, because when I start to think about all the challenges that we face now, I always tend to look back to the history of palliative care. And 25 years ago, very few people knew the phrase palliative care. We didn't have a specialty. And you fast forward to today, and 90% of large hospitals in the country offer palliative care. There are more than 1 million courses that have been taken out of CAPC's curriculum, and people who want to learn basic palliative care skills. I get excited thinking about how palliative care leaders are really getting into positions of influence across healthcare in this country. A couple of recent examples, Nate Goldstein from palliative care leadership at Mount Sinai in New York was just named the chief of medicine at Dartmouth. Arif Kamal, who we'll hear from tomorrow, came out of palliative care at Duke, and he is now the chief patient officer at the American Cancer Society. We have several palliative care representatives sitting on the National Academy of Medicine. So that's that's halls of power stuff that we are doing that was almost unthinkable 25 years ago. And I don't know if you've heard, and if you haven't, breaking news, just a couple of weeks ago, the NIH put out an RFA. The National Institute of Aging is standing up a new initiative and dedicating funding to create a research consortium under the NIA, but in partnership with other institutes and offices across the NIH. They're committed to not just advancing the science of palliative care and serious illness, but to fostering development among early and mid-career researchers, and really thinking about how we evolve quality measures by which we evaluate the experiences of our patients. We all know the measures that we use now are not always a fit. So that is a demonstration of investment and commitment to people with serious illness and to advancing our field. Again, that would have been hard to imagine 25 years ago. So that is a lot to be proud of, and it's due to the work of palliative care and serious illness leaders over the last several decades, a major milestone for our field. So I want to take a moment to think about those milestones.
So leadership. That is, in fact, a strategy. So what is the C-TAC CAPC manifesto or action plan? It is this. It's the agenda that you have over the next day and a half. It is you in the room, and we want to support you. From C-TAC's standpoint, we're doing two things: helping through our advocacy at the state and federal level spread models of care that work from diagnosis through to the end of life, and activating coalitions, national, state, and local, like the Louisville program, behind that push.
Yeah, and at CAPC, we're training clinicians who aren't working on palliative care teams and core palliative care skills. We're really trying to empower palliative care leaders with the messages, the practical tools and the technical assistance that you need to advance your efforts. And we're trying to spread best practices so that they can be replicated across the country. And what we both want to know over the next couple of days is we're in the business of empowering change agents and supporting the work that you all do as leaders in this work. So let us know how we can keep doing a better job of that over the coming years.
Your input is critical on the plan. Thank you so much for being here. We look forward to meeting with you and hearing more about your ideas in the next day and a half. Thank you.
So we're going to segue into an excellent panel thinking about the workforce caring for people with serious illness. But to transition there, what I want to do is introduce the voice of a really powerful advocate. LaToya Francis, and these are descriptors in the order that she gave them to me, but she is a mother, a CNA at a rehab center here in DC, a nursing student, and an advocate and activist. Her message and her words have appeared in the Washington Post, in a number of radio programs. She has testified in front of the city council here in DC. She is a powerful voice who I first met this spring at a workshop put on by the National Academy of Medicine Serious Illness Roundtable. And what she said in that session about her experience being a direct care worker on the front lines, dearly wanting to provide the best quality care that she could to her patients and the challenges she experienced doing that. What she said was so powerful that it's already led to the establishment of a new scholarship program for CNAs who are going to nursing school, sponsored by the Hospice and Palliative Nursing Foundation. Everybody who heard LaToya speak this spring was moved, and I really hope that you will be too.
My name is LaToya Francis. I am a certified nursing assistant. I currently work at a rehabilitation center in Northwest DC. When it comes to describing how I work with my patients, I work with patients in some of the most intimate moments of their day. When it comes to getting them dressed, washing their face, washing their body, getting them dressed, helping them get ready for their day, combing their hair, brushing their teeth, all the basic things behind the scenes that you see when a patient shows up for an appointment or shows up for activities for the day or shows up to their rehab appointments. I help them get ready for that point. What made me get into healthcare in the first place was my basic calling to help. I've always been the type that wants to help somebody, whether it's helping neighbors around the house doing housework that are busy with their jobs or whatever. And I actually became certified as a nursing assistant, a patient care technician, a phlebotomy tech, and an EKG tech. But once I became a CNA on the floor, I was like, this is where I'm comfortable. Like drawing blood and EKGs and all that's exciting, but I want hands-on day-to-day care with people, not just in and out clinic visits. Like I want that connection and time with them. So I've stuck with it this far, and I've been a CNA now since 2015. First and foremost, it's the emotional attachment that you develop with people because, I mean, they tell you not to take things personal because, I mean, sometimes it'll interfere with your judgment and some of the things that the policies would say that you do, but we're all human, you know what I mean? And I know we're not supposed to spend an extended period of time because we still got to share that time to every patient on the floor. Just like yesterday, for example, from work, I was so exhausted after coming home. Like my body hurt because we were super, super short-staffed over the weekend. And now with staffing metrics are still pre-COVID. So what I mean by that is people need way more care than what they did before COVID. People's bodies reacted to COVID in a way that healthcare clearly wasn't prepared for. And that changed the way that we have to care for them. And even in their confused dementia states, they think of me and my family sometimes. So like the fact that you have somebody that will write you a card and say, just thank you for doing what you do for me. I appreciate you. And I haven't seen you, even though it's hard, even though it's stressful, even though at times it is some of the most grueling things that we have to endure. Like, I still love it. I just love those moments. We're definitely not appreciated when it comes to the pay that we get. I make $18 an hour now at base in my facility, and I can't pay my bills on a daily basis. My rent alone is $15.75. So if you do the math of a regular 40-hour work week and $18 an hour, that's not even enough to pay rent with one check. So then you're trying to piece together check to check with just to get rent taken care of, on top of groceries, on top of a teenager that wears a size 12 men in shoes, men's clothing. Like everything is more and more expensive. So it's like I'm stuck in a position where the only way I can find my way out is to finish school and not give up on school, because no matter how hard it gets, I know that's the only way to up my income right now, because clearly the healthcare system doesn't think that CNAs deserve at least a livable wage. Like, it's completely appalling that people like me that watch over people at night and make sure they're still breathing aren't getting paid what we deserve. Like, that is, it's totally disrespectful to the work that we do, because we do so much by comparison, and we spend so much of our time with them. And at these facilities, like, we spend more time at work than we do at home. And then by the time we come home, we're so dead dog tired that we can barely spend any time with our kids. It's exhausting sometimes how much I have to work. And then when you get your paycheck, it's like, I still can't even pay all the bills that are due this week. You know, like, that's the most frustrating part, is when you work as hard as you do and then you see your paycheck, and after taxes and everything else, it's like, wow, this sucks. What would I say to people in leadership that actually make decisions and can actually make things better? What wouldn't I say, first of all? I would say, listen to CNAs. Like, we have a lot to say. Like, I would say, think about giving more opportunities to people like me that have a lot of valuable input, but people have ideas. And if you don't give people opportunities and seats at the table to have input on what can make things better staffing wise, how is it that people that sit in the seats that make the decisions that they make can employ people and think that it's okay that they go home and not have enough food to eat, or not be able to pay their bills, or not be able to have maxed out credit cards? Because it's not like, for me, for example, anyway, I can't speak for everybody else, because it's certainly not the pay that attracts us to it. It's what we love to do. So we should be paid according to the love that we give to our jobs and the dedication to this hard, very important work that we do. The answers are really, really simple. You just got to listen to the people trying to tell them, instead of thinking, oh, I have the degree, I have the certification to do X, Y, and Z, and I'm the administrator, and I've had this many years, and I've done this facility, and I've worked here and there. Well, guess what? So have we. Yeah. So have we. We have experience and values too, and it counts, and it can really help you in the long run, but you choose to undervalue us and not think of us as even an asset to the team. Whenever I have these conversations with people, it's like, you would think that after years and years and years of healthcare workers asking for better conditions, better staffing, better wages, better anything, you know, like, you would think that healthcare would find a way to make it right, instead of trying to find a way to line their pockets and give people that do the most work what they deserve. Safe staffing and better wages shouldn't be that hard to provide, especially knowing how much these facilities make. We still go every day and we still have a smile on our face, and we still try to give our best, no matter how hard it is, every day. And we don't quit.